All right. Just a little bit late, 6:01. Want to welcome everybody to our inaugural hybrid dry needling course. During the course of this last year, we've done a whole lot of Zoom stuff, a whole lot of new ways of doing things. So with our dry needling certification, we also took the opportunity to convert that experience over to a hybrid method. Again, you're the inaugural class. I'm excited about this format. Quite honestly, for some folks have taken some dry needling courses, some have not. It is an awful lot of information to cram into 2 to 3 days at a time, and so I'm excited about this extended format to let us have time to both present the information and absorb it and start thinking about how to apply it. But before we really get rolling into the content, I'm going to turn it over to Ashton and let her cover any housekeeping things that we need to take care of.
All right. Again, thank you all for coming on tonight and for signing up for the course. You should have gotten an email from me either yesterday or today, depending on when you signed up, that had a few links in it. If you're on the Zoom call, then you probably got that email because it had the Zoom link in it. It also had a link to our private Facebook group for the course. This is where all homework assignments will be posted, so you need to make sure you have that. And there, you should have also gotten an email when you registered for your student portal. The student portal is important because that's where all of the recordings of these Zoom calls will be posted. Also, the PDFs of the slideshows will be posted there, and a listing of the homework assignments will be posted on there. If you didn't receive any of these emails or links, please email us at info@hanesptinstitute.com. I'll be monitoring that email tonight as you guys are on this call, and I will do everything I can to get that all out to you. Also, if you see at the bottom of your screen, you have a Q&A and a chat. I will be monitoring the Q&A and the chat throughout the entire course tonight as well. So if you have any questions or any issues or anything, please post those down there. I will, if I know that Luke is going to answer the question shortly, I'll let you know that. Otherwise, I'll jump in and interrupt him and ask your question on live so that everyone can hear. I think that's all I had.
All right. So I'm going to jump right in and get started. There is a whole lot of content that I want to cover. Fortunately or unfortunately, tonight's is background information. It's great information to have, but it's stuff that we have to get to talk about philosophy, theory of dry needling and so forth. But I want to take just a couple minutes to tell you a little bit about myself, why you've taken your time to invest in this course. So I graduated from PT school, Texas Tech, in 1994. I'll be honest, before that, high school, mid 80s, I had no intention of even going to college. My granddad was an old man, my dad was an old man, brother was an old man. I was going to graduate high school and go work in the oil field. Unfortunately, or actually fortunately, the bottom of the oil field fell out, and there really were no jobs at that point. And so all of a sudden, as a young person, I had to decide, well, what do I want to do with my life? As it turns out, I had two brothers who were born with cerebral palsy. One was of normal intelligence, the other profoundly retarded, had about a 9-month-old mentation. And so that brother was actually living in a state school in Abilene. I didn't know it. So it turns out I ended up taking a job as a caregiver, not as a professional staff, but as a caregiver out there while I was going through school. And it turns out, I didn't realize it at the time, but they had a physical therapy department. There was a gentleman worked out there by the name of Rex Nutt. If you read any of the TPTA information over the past couple of months, there was an article about Rex Nutt. He's well published. He's been around, oh goodness, forever. And I say that I've been around forever, but he's been around really forever. Anyway, he kind of guided me towards looking at physical therapy as an occupation. At that point in time, my idea was to go into PT as into that population, since I had a brother that was in that regard, and so that was my idea until I got into PT school, and then I got there and I really fell in love with orthopedics. So fast forward a little bit. At that point, at Texas Tech at least, the degree was a bachelor's degree. They were just now starting to talk about the master's, and then a little bit later moving on to the doctorate. Well, fast forward, I went into my first doctoral program, the SED program, and decided, after about a year and a half, I decided I really wasn't that interested in teaching. I wasn't interested in research. And so I changed. I went to just a transitional DPT, finished that in 2012. And, the funny thing is, now that I've gone through that, now really what I want to do is teach and research. So it's kind of full circle about how life can happen. Anyway, after I finished my DPT, I started looking at dry needling. Like so many people at that point, I thought dry needling was a joke. I thought it was just a flashy thing that people were doing, and there really wasn't anything behind it. But I needed some CEU, so I decided to go take a course. Well, so I took one course, came back, started applying what I learned, and went and took a couple more courses, got a certification, and kept on using it. Went through a different program, and it had a completely different philosophy. One was more acupuncture based. And so came back to a clinic with a second certification and started using that approach. And it turns out what I learned clinically along the way, that there was a mixture of the two, and then some things just from traditional orthopedic physical therapy practice that really was what needed to happen. So I went on an adventure to deconstruct and then reconstruct what dry needling should be and how we should apply it to our patients. And the net result is what you're here to learn, which was what I call the Haze Method. Had it copyrighted and through U.S. Patent and Trademark Office. And so that's what we're going to be looking at over the course of the next 7-8 months. If I get excited about it, it's because it's something that I'm passionate about, and I really feel strongly with the methods and the teaching that we do here. So that's a little bit about me. Let me get past that. So this is lecture 1. Again, there's a whole lot of information to get in through here. And I'm going to jump out just a second. Ashton, will you bring me a clock or a timer? Actually, let me pull my watch off so I can keep an eye on where we are. I don't want to get too far. I can chase squirrels sometimes, so if I get off track, Ashton can just bump me back in. So anyway, this is lecture number 1. This is basically our introduction into dry needling. For people who are watching this recorded or asynchronously, definitely you need to go through all of the content. There are assignments at the end. I'll be honest, these are not terribly difficult assignments, but they're definitely things that will help us make sure that you did attend the class. And more importantly, there's actually a needling session that we'll go through towards the end. If you should get this in the introductory email that you get, but we will, if you don't have access to needles going into this first course, I want you to reach out to us via email. Let us know. We'll send you a small packet of needles so that you can practice the introductory skills. So the Haze Method of neuromuscular dry needling, the hybrid certification, it is a 64-hour dry needling certification. It is presented in this hybrid context with 32 hours being live, synchronous, and actually also asynchronous virtual lecture, and the other 32 hours being live in-person lab sessions. The lecture is broken into 16 two-hour lectures, which will occur every 2 to 3 weeks on Mondays from 6 to 8 Central Standard Time. This introductory 8-hour in-person dry needling lab will take place after the first 4 lectures. We just brought on a hosting clinical lab site in Yadkinville, North Carolina. We're in talks with one in Austin right now. And as the year progresses, we hope to see quite a few more locations across the state, across the country, so that we can make this format available for more people. Then there will be an advanced in-person dry needling lab. It'll be a 3-day, total of 24-hour lab that will occur after the 16th lecture. Ours here in Weatherford will be on December 3rd, 4th, and 5th. I believe in North Carolina that's going to be December 10, 11, and 12. Those participants who successfully complete the entire course and wish to demonstrate the advanced clinical competency can sit for both a written and a practical examination, which, once completed, will lead to a certification in the Haze Method of neuromuscular dry needling. So, course objectives, here we're going to define dry needling. We'll differentiate between dry needling and acupuncture. A patient, every other patient is going to ask you, well, is this acupuncture, or what's the difference between this and acupuncture? And I hope I give you a good answer to that question. We'll identify the appropriate patient population and conditions that may benefit from dry needling. We'll demonstrate proficiency and competence with needle application and safe needle technique for both the patient and the practitioner. And then we'll identify the appropriate dosing of dry needling necessary to treat an acute, subacute, or chronic neuromuscular dysfunction. We'll describe indications, precautions, contraindications of dry needling. We'll discuss the locations, the anatomical structures, and the danger zones of dry needling to ensure patient safety. We'll discuss the current best evidence related to dry needling. I think this class is all physical therapists. We'll discuss the level of proficiency needed by the PTA to satisfy the PT requirements to perform dry needling under the PT supervisor, and what areas are and are not appropriate for the PTA. Texas is the only state that allows PTAs to engage at this point in dry needling. And so a lot of the structure of this approach is such that the PT can really lay out specific protocols, and we'll talk about how that works and what the PTA can and can't do in that regard. It will also work for the OT-CODA relationship as well. And then lastly, we'll identify specific treatment rationales and protocols for various diagnoses and body regions. The Haze Method is a unique approach to dry needling, developed after practicing using both a trigger point and an acupuncture method in over 50,000 patient encounters using dry needling. I was very fortunate that I had basically free reign, being in private practice, to experiment, for a lack of a better term, experiment or practice with what worked and what didn't work. And it really gave me the opportunity to look at a lot of different options as far as dry needling. HMDN was developed after applying the most common treatment approaches in dry needling and learning which were effective and which were not. Dry needling is not and should not be used as a standalone treatment. We'll talk a little bit later when we talk about dosing. The outcomes of a single dry needling session without follow-up with other treatment to go along with it. In fact, dry needling, it's simply a tool used to decrease pain, inflammation, or neuromuscular dysfunction to a level that will make the remainder of the subject's treatment more tolerable and more likely to achieve successful outcomes. It is to be applied similarly as we would use a manual therapy approach, or a manipulation, or instrument assisted, or cupping, or any manual technique that we could use. This is the same thing. My opinion, it's the best one we have out there. And dry needling should almost always include some form of manual therapy to restore motion strength and return prior function. HMDN is not a philosophy based on trigger point therapy, meridians, or chi. A lot of the traditional dry needling approaches are purely focused on the notion of the muscle trigger point. Most of the research that we see is about dry needling trigger points, and we'll look at some trigger point charts or a chart in a little bit. I've found that the trigger point is not necessarily the right approach. It's based on the concept of identification of a focal point or points of inflammation in a movement system, and then subsequently using the needles to stimulate the body's own inflammatory responses to reverse the course of that dysfunction. And might it include a trigger point? It might. However, it's actually possible, and research shows this, to identify a focal point between two clinicians and have empirical evidence to support where that location is. It just doesn't exist. We just don't have that manual ability to do that. So the answer is specifically no. Looking at the charts developed by Travell, we know that there is a large variance in trigger point locations. Further, traditional theory would have clinician repeatedly piston the needle, and we'll go over that in a little bit. The needle until a twitch response is gained. My patients have never been a fan of that, and you as the student involved in lab sessions also would not enjoy that. So therein lies a component of poor outcomes based on a patient refusal of further treatment. So I'm not a big trigger point guy. I'm not an acupuncture guy, but what we use these tools to do, we can get a great response without going to that extent. So HMDN, it's based upon the 3 phases of healing, quite simply. Our phase 1 goals, we're going to try to control pain and inflammation and prevent loss of motion. Our phase 2 goals, to restore normal motion and strength. And then finally, our phase 3 goals, to maximize motion and strength, prevent re-injury, prevent future pain, and then simply get back to life. Dry needling is almost always limited to use during phase 1. During this initial phase, assessment will need to be focused not solely on pain. More to the point, the goal of assessment should be on finding the focal point of inflammation in a movement system. Furthermore, rarely is successful dry needling treatment limited to single muscles. There will always be a strength and flexibility issues at other components of the movement system that will be required to be addressed in order to give the patient a maximal probability of restoring that system back to normal. Most of my treatment protocols, so going through this approach, we definitely will learn to needle almost every muscle in the body, including some that you wouldn't think that we would. But more importantly is learning how to group these muscles into a specific movement system. Say around the shoulder, there's a lot of movement that takes place there, and it's rare that it's just one single muscle. Let's say we have a rotator cuff tear. Well, we definitely can needle that and get some good response from that. But is it just the supraspinatus, or could subscap, could infraspinatus be involved as well? Is there some impingement going on? We have to address all of those components, and with dry needling, it gives us a tool to do that. As an example, a patient could present with knee pain. It should be evaluated to determine the following. Which specific components of the knee are tender and painful? Is there a ligamentous or a tendinopathy involved? Are they tender to palpation? Are they more tender during active or passive movement? Is the pain leading to restricted motion and strength? What are the other structures involved in the system? Are those structures demonstrating inflammation locally, proximally, or distally? Are other movement systems affected proximally or distally? Is there a neurological impairment coming from the spine? And then is there a neurologic impairment distally, such as entrapment or compression? So a lot of things we have to look at besides just a specific muscle that we might want to dry needle. The evaluation is very dynamic. It's based upon the responses from each movement system, and it'll need to be reassessed at each follow-up treatment session. One of my big pet peeves is just repeatedly needling that same muscle over and over and over again without change in approach. More often than not, so my protocols are layered into a minimum of 2, if not 3, dry needling tiers. The first tier always includes the biggest muscles, and then we move into the smaller movers as we move down through the protocol. So at each subsequent visit, we have to determine through palpation, is the upper traps, is it under control now? Do we need to move down into some deeper structure? Or has it moved more centrally into the spine? So the assessment is key, both on initial assessment and then on each subsequent assessment. Additionally, returning your patient back to normal is based upon giving them a direct approach to managing their symptoms. As you identify and treat the focal points of inflammation, the patient should be assigned work to do at home for the flexibility of target tissues, and that's for inflammation reduction, and then strengthening, which is for restoration of function. Without stating the obvious, it's critical for the practitioner to be skilled at identification of landmarks and structures of the human body. It'd be impossible to needle targeted structures without being able to precisely identify them and differentiate them from other structures. A 3D anatomy application is critical to relearning the relevant structures. So I say that to go to the idea of relearning anatomy. When we live in the world of trying to strengthen the quads in order to do a better sit to stand or complete some other functional task, we definitely need a relative idea of where it's attached and where its origin, where it's attached. But if we want to dry needle the origin of the tendon of rec fem as it attaches on the AIS, well, we have to know where that is. We need specific landmarks and we need specific dimensions of, and what we use is either finger breadths or thumb breadths to identify landmarks. And so that 3D anatomy is critical for that. Depending on the patient's situation, they may be able to be treated in the seated position. They may be only able to tolerate a sideline position in and around the back and the hip. They may not be able to get prone if they're older dealing with stenosis. And so that three-dimensional view of where these structures are and your needle location is critical. HMDN is presented as following. We're going to look at general concepts of dry needling. We're going to look at how to dry needle specific introductory muscles, and we will dry needle complex muscles, tendons, ligaments, and nerves as we move past this introductory material. And then we'll look at specific diagnosis related dry needling protocols. And then finally, for each section, we'll look at specific perineural dry needling protocols. A lot of I call this neuromuscular. Definitely the muscles play a big role, but the neurological component is critical, whether we're dealing with something such as peripheral neuropathy, if we're dealing with carpal cubital tunnel, a lot of the entrapments in the upper extremities, lower extremities as well. So that'll be the final piece, is that perineural dry needling protocol. The last course or the last lecture in this series will be on the pelvic floor. There is a lot of good information in there. One of the more common ones we deal with is both pelvic pain and then incontinence. And dry needling can play a big role in managing those symptoms. And then finally, HMDN is based on the concept that learning never stops. Principles learned in this course will give the certified practitioner an advanced level of skill and knowledge to implement dry needling into your practice. But as you become more skilled in the technique and in the response of your subjects to its application, you'll be able to modify the techniques to adapt to the responses you see. Human body is a larger scope of knowledge than we'll ever conquer, however, and new techniques are frequently being developed. I developed a new approach for dry needling the glenoid labrum a couple of months ago, and I've now implemented that almost with every shoulder patient that I see. For thoracic outlet, I talked to my staff earlier today. There's a much more advanced approach for that. We've got a specific solid approach for a thoracic outlet, but there's a much smaller muscle and a much more potentially complex and dangerous location. I'm just studying right now how to get to that, how to needle that in a safe manner. And so we're going to continue to learn more as we move forward and apply these things. So on the idea of research, ongoing research needs to be reevaluated. The majority of research being conducted is based on the outdated trigger point theory and not on movement systems. Further, the actual needle locations are rarely included in the research, and that is a failure. For how can the research be duplicated if we're not able to use precise locations in treatment? HMDN provides specific landmarks, distances, and depths to improve upon standardization of this technique. I frequently get an update every week on new research that's being put out, and every week there's a new research study on the effects of dry needling on the upper trapezius. I think that is the most studied muscle in the history of the world, and quite honestly, it's the easiest one to dry needle. We know that it can help reduce stress and tension. We know that it can help with things. There are 6,000 other things that they could be doing research on to really help our profession and the practice of dry needling. So hopefully as time moves forward, the focus of research will shift just a little bit so that we can get a little bit more meat into what we're putting out there. So the history of dry needling, I don't take a whole lot of time here, but quite honestly, the modern dry needling, its roots comes from the work of Janet Travell, her book, Myofascial Pain and Dysfunction, the Trigger Point Manual. She uses the term dry needling to differentiate between the use of a hypodermic needle for treatment, where in there she uses an injectate, and in the true dry needling, there is no injectate, so she calls that dry. She is notable for coining the term, the trigger point or the myofascial trigger point, and the treatment of trigger points with needling, either wet or dry. Her artwork, which I've kind of shown here to the left just a little bit, from that book have been no doubt part of the education process for any clinician studying muscle dysfunction. Although dry needling originally utilized only hypodermic needles due to the concern that solid needles had neither the strength or the tactile feedback that hypodermic needles provided, and that needle could be deflected by dense contraction knots. Those concerns have proven unfounded, and many healthcare practitioners who perform dry needling have found that the acupuncture needles not only provide better tactile feedback, but also penetrate the muscle knots better and are easier to manage, and they cause less discomfort to the patients. I can definitely vouch that they cause less discomfort than a big gauge hypodermic needle. Patient will let you come at them with our acupuncture needles much faster than if we pulled out a big hypodermic to go after, especially if we're doing 5, 6, 7, 8 needles at a time. Traditional Chinese acupuncture itself, it dates to about 100 years BCE, although there have been instruments found that are thought to have been used as acupuncture tools, and that dates as far back as 6000 BCE. It's explained as a technique that can balance the flow of qi, your energy or your life force, which is described as flowing through meridians throughout the body. Western medicine itself, dry needling, it places no impact on the concept of qi or meridians in treatment. It is true that there is occasionally some correlation between traditional Chinese acupoints. The key difference between dry needling and traditional Chinese medicine is the why and where of needle placement. So as you begin your dry needling practice, you'll have a lot of people come in and say that they had great or they had poor results from acupuncture. I'm absolutely going to knock people who practice acupuncture. My general statement is that I don't, and this isn't entirely true, but this is what I say. I don't know that much about acupuncture, so I'm not going to try to infringe upon what they do. And we'll look at an acupuncture chart here in just a second. If I want to treat shoulder pain as a Western physical therapist, what I want to know are what specific anatomical structures are creating that pain. Is it coming from the neck? Maybe at a first rib problem. Is it a nerve impingement in between? Is there a problem with the subacromial bursa? Is there a bone spur? I don't care about the lung meridian and treatment of that. I care about those structures that I can identify as being a focal point of inflammation, and inside our movement system if they create and recreate that pain. So big difference between acupuncture and dry needling. So we do look at, this is the traditional Chinese meridian map. I've got a text in the other room that's about 2 inches thick, huge book that goes into much more depth about this. I will give the acupuncturist credit. There is a lot of information that they have to keep memorized on specifically where these locations are. But as you can see, there's a lot of odd placement of the meridians coming down the arm, the trunk itself, into the back, down the legs, into the toes. Down at the bottom left, you see they treat according to the fire, earth, metal, water, and wood. I don't know anything about those things. They take tongue pulses. Well, I don't know what tongue pulses have to do with my shoulder or my calf pain, and so I'm going to leave all of that to the acupuncturists who are trained and licensed in that approach, I want to stick with Western medicine. So I looked at some common points for knee pain. And I mentioned that there can be correlation between these different pain problems and what we do as dry needlers and what they do as acupuncturists. So just osteoarthritis, I mean, obviously they're going to do a little needling above and below the patella. They're going to get out in the lateral calf, either anterior tib. They're definitely going to get it at the stomach 40 here. They may be looking for extensor hallucis longus in 41 and in 3. So there can be a lot of correlation. However, why they needle and why we needle is going to be a lot different. I'm not concerned about people's energy and their life force. I hope everybody's energy and life force is good, but we want to stay and stick with traditional Western anatomy and physiology. So they also look at auriculotherapy. According to traditional Chinese medicine, the body can be duplicated throughout the ear in certain locations. And so the idea is let me find one here. If you want to, the inner ear, the inner nose, let's say you want to do something for the sacral spine or the hip, then right above the tragus, then you could drop a needle right into there. I will be honest, I've tried this just to experiment and play. I saw no benefit, but I'm also not trained in auriculotherapy. So again, we want to stick with traditional physiology, anatomy, and treat those pieces and let the acupuncturist stick with what they've got. So the APTA defines dry needling as a technique physical therapists used where allowed by state law. And we'll talk about that in a minute. I didn't bring that up. For the treatment of pain and movement impairments, technique uses a dry needle, one without medication or an injectate, inserted through the skin into areas of the muscle. Other terms commonly used to describe dry needling include trigger point dry needling and intramuscular manual therapy. It's not acupuncture based on traditional Chinese medicine. It is a part of Western medicine principles and supported by research. One area I don't think that the APTA went too far in this position statement, and I don't think they've updated it. We don't just treat muscle. Whenever we deal with tendinitis, with neural impingement, these are structures that we can address as well. They did get it right when talking about movement impairments, but that so often can include things other than just the specific muscle. So the physiology, we'll talk a little bit about this. Actually, we're going to talk a good bit about this. So as a general statement here, research is ongoing concerning the physiology surrounding the response to dry needling. Generally speaking, it's agreed that dry needling will increase blood flow in the area. It'll decrease taut muscle banding and the tenderness or sensitivity associated with them, and they can decrease the spontaneous electrical activity or the twitch response. Although some research suggests that may not be relevant for successful outcomes in dry needling. And there's also some CNS and some biochemical changes that can occur, suggesting that there are local changes, but also more distal and proximal changes as well. So that came from a collection of studies from the early 2000s, or the 2010s. So why are we dry needling and why does it work? If you've talked to anybody who's had dry needling, you may have had it done yourself, you know that you get a really good, strong response most of the time. So why does it work? And more specifically, to know why it works, what is causing the pain and the tenderness? So we have a patient that comes in, presents with, and we've been talking about the shoulder, let's keep with that, with some posterior shoulder pain. And you go to evaluate, and there's some real tenderness on that backside. You can almost feel that rope laying in there. Well, what causes that pain, that tenderness? Well, again, the taut bands in the muscle, they can be palpated, identified as the focal point of pain and the tenderness. My approach is around thinking of those taut bands as a low-grade persistent muscle contraction or a cramp. And so why does that muscle stay contracted? So from there, let's explore the mechanism of muscle contraction. We want to look at, and so we're going to jump back to, for me it was much longer ago, anatomy and physiology. We'll talk about the neuromuscular junction. We'll talk about skeletal muscle contraction, and then the basic mechanisms of musculoskeletal pain. So in the neuromuscular junction, the term neuromuscular junction, it refers to the synapse between the motor neuron and the skeletal muscle fiber. The activity at the neuromuscular junction is essential for the contraction of skeletal muscle. And I'm going to give you a hint. One of the homework questions deals with this section. So, activity at the neuromuscular junction is essential for the contraction of skeletal muscle to occur and even to keep muscles from atrophying. When a motor neuron approaches a muscle, it branches out into several extensions that end in areas called the synaptic boutons. These can release neurotransmitters, and these synaptic boutons are situated over a specialized region of the cell called the end plate, or the motor end plate. The synaptic boutons are separated from the end plate by a space called the synaptic cleft. The end plate beneath each synaptic bouton contains several deep indentations called the junctional folds. And these junctional folds contain high numbers of ligand-gated ion channel receptors for the neurotransmitter acetylcholine. So at the neuromuscular junction, acetylcholine, we'll find out in a second, acetyl cholinesterase is the critical thing to get that nerve impulse from the nerve through the motor end plate into the fiber itself. So when an action potential travels down to motor neurons, so we're sitting here, I'm thinking I want to lift my elbow. So to do that, the brain has to send an action potential down that motor neuron, down to our synaptic bouton. So when that happens, it causes the release of acetylcholine into the synaptic cleft. Acetylcholine then binds to the acetylcholine receptors in the junctional folds themselves of the muscle membrane. And this causes the ion channels to open, which allows positive sodium ions to flow into the postsynaptic cell. This produces a depolarization of that cell, called an excitatory postsynaptic potential, also known as the end plate potential, and when it occurs at the neuromuscular junction. This depolarization leads to the opening of the voltage-gated sodium channels, which causes the end plate potential to lead to an action potential. And then this action potential travels along the muscle fiber and causes the contraction of muscle. So there's a whole lot of stuff going on in order just to get that thought down to the muscle. So again, acetylcholine, and we'll talk acetylcholinesterase next. The enzyme acetylcholinesterase, it's present there in the neuromuscular junction. Its job is to break down acetylcholine, and in the process, it terminates the effect of acetylcholine on the muscle fiber, thus ending the communication between the motor neuron and the muscle fiber. So acetylcholine allows that signal to go through. Acetylcholinesterase breaks it down and makes it stop. So let's move on to what a skeletal muscle contraction looks like. So the skeletal muscle is, they are composed of bundles of muscle fibers. So here's the skeletal muscle. Around inside that we have the muscle fiber bundle itself. And then inside of that we have the specific muscle fibers or cell. And they contain several nuclei along the way. The muscles will contract or relax when they receive signals from the nervous system. The neuromuscular junction, it's the site of the exchange. This is where the synaptic bulb or the bouton of an axon terminal and a muscle fiber connect. So here we look at the myofibril. That is, let me come back. So the myofibril will then come out of, is the smaller unit of the muscle itself. It contains contractile units called the sarcomeres. The sarcomeres run adjacent to one another down the length of the myofibril. Each sarcomere consists of alternating thick and thin protein filaments, giving skeletal muscle its striated appearance. The muscle contracts when these filaments slide past each other. So here we have the thick filament and then the filament. Thin filament. They slide past each other. The thick filaments are the myosin, and they are anchored at the center of the sarcomere called the M line, right here. and myosin here. The thin filaments are composed of the protein actin, which are anchored to the Z lines at the outer edges of the sarcomere. And so because the actin filaments are anchored to the Z lines, the sarcomere is shortened from both sides when the actin filaments slide along the myosin filaments. So it moves together all at once. So although the action between the filaments is described as sliding, the myosin filament actually pulls the actin filament along its length. The cross bridges of the myosin filaments attach to the actin filaments and exert force on them to move. This action is known as the sliding filament mechanism of muscle contraction. In this model, the sarcomeres shorten without the thick or thin filaments changing in length. So a contraction begins when a bound ATP, adenosine triphosphate, is hydrolyzed to adenosine diphosphate and an inorganic phosphate. And so whenever this causes the myosin head to extend and attach to a binding site on actin, forming a cross bridge. An action called the power stroke is then triggered, allowing myosin to pull the actin toward the M line, thereby shortening the sarcomere. The ADP and the inorganic phosphate are then released during the power stroke, but the myosin remains attached to the actin until a new molecule of ATP binds, freeing the myosin to either go through another cycle of binding and more contraction, or to remain unattached to allow the muscle to relax. And so here this is in just a little picture, little movie. So we create our cross bridges. It helps, it does the power stroke, it pulls that actin further across, and it keeps on going. As this happens, we're getting ATP is going to break down into ADP and inorganic phosphate. It's going to pull the power stroke, it's going to release. ATP has to come back again and then break that ADP or attach and bind in order to restart the cycle. And so this happens on a super fast, very rapid basis. ATP comes in, releases it from the binding site, transforms again, and it just happens extremely quickly. So we talked about, let's see what else we've got here. We talked about how acetylcholine lets the nerve transmission go from the brain through the nerve down to the muscle. So we've got one set of chemical reactions taking place there. Now in the muscle itself, we've got something else that's going on of chemicals that have to bind, have to unbind, and have to bind again in order to release that muscle. So a lot of potential things happening here. And then further, we've got the action of calcium. The thin actin filaments are associated with regulatory proteins called troponin and tropomyosin. When a muscle is relaxed, tropomyosin blocks the cross-bridge binding sites on actin. So we've got troponin, and then which binds the site, and then we've got tropomyosin. Tropomyosin blocks the cross bridge. So when the calcium ion levels are high enough and ATP is present, the calcium ion will bind to the troponin, which displaces the tropomyosin, which exposes that myosin binding site on the actin. And this allows myosin to attach to a binding site on actin, forming a cross bridge. So we've got yet another thing that's taken place that very well could be responsible for this muscle tension, this low-grade spasm that's going on. Calcium ions are stored in the sarcoplasmic reticulum and are released in response to signals from the nervous system to contract. The neurotransmitter molecules are then released from a neuron and bind to the receptors, which depolarizes the membrane of the fiber. The electrical impulse travels down the T-tubules and opens the calcium stores. The calcium ions then flow to the myofibrils where they trigger the muscle contraction. As the actin and myosin slide along each other, the entire sarcomere shortens as the Z lines draw closer to the M line. And as the sarcomeres in myofibrils contract, the entire muscle fiber will shorten. When the muscle fibers contract in unison, a muscle can produce enough force to move the body. So let's talk about the basic mechanisms of pain and see how that could be impacted as well. So here we're going to talk about these myofascial trigger points. They can be a common cause of non-articular musculoskeletal pain. They're discrete, palpable hyperirritable nodules in the top band of skeletal muscle that can only be diagnosed by systematic palpation of the soft tissue. So this is a little bit old in this statement. You can actually, at times, you can see on musculoskeletal ultrasound, you actually can see some of the trigger points, that tight banding of muscle, if it's significant enough. Activation of group 3 and 4 nociceptor afferents causes that pain and tenderness experienced at motor trigger points. One mechanism of musculoskeletal pain is initiated when noxious stimuli deform the axonal membrane of a muscle nociceptor endings beyond their firing threshold. This causes a release of a variety of biochemicals such as bradykinin, prostaglandins, and serotonin, among many others, from muscle tissue, which may stimulate group 3 and 4 muscle fibers. That biochemical cascade can also be elicited without mechanical trauma to the muscle. So once sensitized, the group 4 afferents will fire the lower threshold, responding to an innocuous stimuli like weak pressure or muscle movement. This causes the exquisite tenderness of the active trigger points. This is called peripheral sensitization. Continuous input from the myofascial trigger points can also increase excitability of the dorsal horn neurons. And this is called central sensitization. Here we can see allodynia, hyperalgesia, and it can also open previously ineffective synapses, resulting in new receptive fields and the referral of pain. Also, stored substances in nociceptor endings also affect microcirculation through vasodilation and plasma extravasation. The nociceptive input from skeletal muscle is much more effective at inducing neuroplastic changes in the spinal cord than input from the skin. So that this dynamic process can fundamentally alter pain threshold, pain intensity, and emotional affect. Okay, so I went through all of that to get down to this. So what is responsible for the muscular pain we are treating? We look at different approaches to dry needling, and in some cases they're looking at the trigger point theory. Some are looking at the gate theory. There's a lot of potential theories out there, but if we don't know where this pain is coming from, then what are we needling and why are we needling it? So is it the traditional trigger point theory? Going through all these slides, we know that ATP releases the actin and myosin cross bridge. So is that spasm, is that low-grade tension, is ATP insufficient to allow for the release of the cross bridge and thereby maintaining that low-grade spasm or the contraction that we can palpate? The acetylcholinesterase, it unbinds acetylcholine at the neuromuscular junction. So is acetylcholine, is it remaining bound at the neuromuscular junction and maintaining that constant depolarized state, allowing for ongoing spasm or contraction? Which is at fault for the continued contraction? Is it the Golgi tendon organ? Is it centrally mediated? Is there a locking at the spinal segment that's creating aberrant conductivity to the neuromuscular junction? There are lots of theories there, and quite honestly, it could be a little bit of all of that stuff. It could be local trauma. We know that the body responds to trauma and injury by contracting muscle. Where is that mediated? That's probably more centrally mediated. Very frequently we'll see a subacute or a chronic condition that still has that low-grade muscle tension. It's tender. They've got that, for lack of a better term, they've got those trigger points going on, that taut muscle banding. So why are they staying that way? They're not. It's voluntary musculoskeletal contraction. So what's causing that to happen? So again, a lot of theories. I don't know if one of them is better than the other. It could be any of those things. So let's talk about needle safety. Let me take a quick little sip. So gloves. There's an ongoing debate among the different schools of thought concerning the use of gloves. Acupuncture associations discuss the loss of dexterity with gloves and the inability of gloves to prevent a needle stick. However, it's always recommended use universal precautions and use gloves anytime there is a risk of exposure to bloodborne pathogens. And they're absolutely right. If I'm dry needling somebody, and I will say I've probably used approaching 500,000 needles that I've inserted while I've been dry needling, and during that time I've only had one accidental stick to my finger. I don't care if I had 14 gloves on, it would not have prevented that needle from going through there. However, from time to time we do, it's rare to have blood with dry needling. However, there is a risk, and maybe 1 in 10, you will have a little droplet of blood that comes off of there. Anytime we have the exposure, great idea. Let's have those gloves just in the case of the blood exposure. Does it change dexterity? Depending on the thickness of the glove. So if the mill thickness of the glove is too thick, it does get a little challenging to do that. I'll demonstrate some of our smaller needles here in just a minute. There are some of the really short needles that, especially, so I've got really big hands. With gloves on as well, it does make it hard to manipulate that. But a general rule of practice for institutional providers, definitely policy and procedure needs to be in place for use of gloves during dry needling. Skin prep, it doesn't have, so dry needling is a clean technique, it's not a sterile technique. Patient skin should just be clean and free of any contaminants. Never a bad idea to cleanse it with an alcohol solution. Allow it to dry for 10 up to 20 seconds prior to treatment. The reason for that delay is if it is wet with alcohol and you insert that needle in, you're going to carry a little bit of that alcohol in with that needle, and they're going to have a little bit more discomfort than they might like. So definitely want to do a little skin prep. Needle disposal, definitely want to have a sharps container nearby. Needles are only used once, except in rare occasions. The needle tip will dull after more than one usage, especially if periosteal pecking was performed, and it should not be reused. Definitely want to have appropriate size sharps. Disposal container in the immediate vicinity, and dispose of the needles immediately after removal of the patient, removal from the patient, and don't overfill those sharps containers. They will fill up faster than you might think. So just an electron microscope image here of a new fresh needle on the left, the good. The bad in the middle might happen after a needling down to bone, down to periosteum. You can tell it doesn't take long for that sharp point to get dented. By the time you start taking that needle, or the one on the right, heaven forbid, the ugly one, and try to reinsert it into a person's skin, they're not going to like you a whole lot. And more to the point, it's not going to enter the skin very effectively. So if at all possible, use the thing just once. If you hit bone or a dense structure, definitely toss that after that first application. Absolutely, you don't use needles in between patients. I do have patients from time to time ask me that. If we reuse the needles, if we clean them, the cost of needles is relatively cheap. You can get them as cheap as about 3 cents per needle up to 15, 20 cents per needle. So practice like mine, where we use a lot of needles, we go for still really good needles, but we also look at cost. On the topic of needles, I have used a lot of different needles over the years. I haven't found needles that I'm unhappy with. I tend to stay with one particular provider, and they've always provided good product. So we can talk about the different needle providers. Actually, I think in the email that went out, it mentioned who we buy ours from. I can provide other people out there that do manufacture needles for dry needling if you want other options. Handling needles. Best practice dictates that the shaft of the needle should not be touched with the bare skin or with untreated gloves. So good idea. Yes, the glove comes out of the box. It should be clean. Never a bad idea to throw a little alcohol on there. Rub those gloves around for a little bit. Get your alcohol swab. Prep the skin a little bit. It just gives one extra layer of protection. When using longer needles, it can be necessary to use the fingers of the non-needling hand to keep the part of the needle penetrating the skin to keep it oriented in the plane desired. To guide the shaft of the needle, the glove should be used and cleansed with isopropyl alcohol with 70% concentrate, 60-70% to the gloves, and allow them to dry prior to touching the shaft of the skin. When we get together for the lab session after the 4th lecture, this will make a whole lot more sense. Short needles are very easy, quite honestly, to penetrate, break that surface tension of the skin. But we'll look at some other ones over here in a second. When we get some longer needles, you've got to guide that needle down. So when you do that, you want to make sure that you have a clean surface that's touching that needle, because that will be penetrating into the skin. Re-sheathing. Caution should always be taken when reusing a needle. To re-sheath the needle into the guide tube, we're going to turn the needle with the handle facing down and block the end with your ring finger. We're going to insert the needle into the guide tube and allow at least 5 millimeters of the handle to exit the guide tube, and we'll use the index finger to hold the needle, the guide tube unit, stationary, making sure that the sharp end of the needle does not extend beyond the guide tube. You're listening to me saying these words, and that sounds like a whole bunch of gobbledygook. So I'm going to switch my camera here, and I want to demonstrate that. So let me stop that share for a bit. Okay. So if you can see here, I'm going to take the needle right there. So here is our standard package needle. They tend to, so needles can come in either an individual prepared package, or in some cases they'll come in a multi-pack, either a 5, 6, or 10 needle package. People that didn't have access to needles, I probably am sending you a 10 pack so that you have plenty to play with. So in the re-sheathing concept, so I'm going to pull this needle out. And since we're talking about needles, we'll talk about this particular brand. This brand comes with a guide tube. Let me pull these out. See if we can see these things. The needle, a guide tube, and then a feather. The feather's job is simply to hold that needle inside the guide tube. There are some manufacturers that their needles have a small bit of glue right here at the guide, where the guide tube attaches to the needle. And to remove those needles, you simply pull the needle away from that side, and it'll snap, and then the needle is free. I like those needles. Their cost goes up, so because of the volume, I tend to take a little extra time and deal with a little feather. So on the idea of re-sheathing again, so I've done my dry needling. Let's see, I need to move up the arm and needle something else. So basically what I'm saying is I want to take and place my ring finger at the bottom of the tube. I'm going to then take the needle and I'm going to insert it handle first. You never want to insert the needle with the needle first. That'll hit you really quickly. So I'm just going to take and drop handle first into the tube. I'm going to allow it to come out about this far, not very far at all, just enough so that I can then put some pressure. I'm going to bend it, and now I can grab the guide tube again, and now I've got control of that needle. This does take a good bit of time and practice. This won't be this will be part of your first homework assignment. I know that sounds silly, but I want to watch, among other things, the net result of you spending a little bit of time just re-sheathing this needle. The manipulation of the needle in front of a patient is critical. The last thing you want a patient seeing is a person being all thumbs trying to get the needle out of the package, and that doesn't inspire a whole lot of confidence. So getting really versed in needle manipulation just with you as the practitioner becomes really important. So that'll be piece number one. See, I even did it myself. Is right there. So that's re-sheathing. All right. All right, let me go back to my share. Okay. So let's talk a little bit about contraindications. Very first, lack of clinician competence. If I was talking to my clinicians earlier today, we were talking about dry needling of the scalenes. We will get to dry needling the scalenes in this course. Scalenes, we've got anterior right here. We've got middle and posterior. obviously I say that we're going to stick needles in here and you're going to get a little concerned and hesitant. Well, it can absolutely be done very safely. It requires specific technique and some skill. But any time that you're uncertain about a location to dry needle, you need to not do it. The last thing we want to do is cause some injury that we could avoid. So clinician competence, number one. First trimester of pregnancy, there's good medical, legal reason to avoid that if at all possible. Have I dry needled during all terms of pregnancy? Absolutely. You just want to be cautious because of the potential for miscarriage during that first trimester. We have no reason to needle the nipples, the umbilicus, external genitalia. Someone who has uncontrolled anticoagulant usage, someone that's on a blood thinner is fine as long as that their coagulant status is under control. If there's a local infection, if there's an active tumor in the area, want to be cautious into the occipital or the suboccipital region of the patients with a Chiari malformation. Over a pacemaker, a defibrillator, or any sort of implanted electronic device, and then specifically around the rib cage without advanced training. One of our biggest concerns is for pneumothorax. There are cases where we can needle onto the rib itself. We cannot do that if we cannot, with 100% certainty, palpate the path of the rib. Anytime there's potential for going a little bit out of sync and going into that rib or into the lung field, then we have to stay away from it. But we'll talk about that more in just a bit. Some relative contraindications. So for surgical patients, post-surgical, we want to stay away from any communicating tissue during the first 6 weeks. If it is in the direct area of surgery, we want to stay away from that for up to 12 weeks. If surgeon comes in and says, nope, I want that thing dry needled, that's the surgeon's call. He's in charge of that op site, and so I'm comfortable doing that. But just to be certain on the idea of infection, we want to take that 6-week communicating tissue, and then 12 weeks for the local area surgically. Relative, again, autoimmune diseases. If there's history of lymph node removal, say upper extremity, we want to be fairly cautious there. I actually want to stay away from it. And then any sort of significant respiratory illness, we don't want to confuse potential pneumothorax with respiratory illness as well. Just general precautions, needle aversion or phobia. Some people just are horribly afraid of needles. And so if they can't consent and give their okay on that, then you gotta not. If there's significant cognitive impairment where they can't reasonably consent to the treatment. Likewise, if there's a communication barrier. If they do have a history of traumatic or spontaneous pneumothorax, if they have severe hyperalgesia or allodynia, it doesn't happen often, but you can have a metal allergy. Every needle that I've used is a stainless steel needle, but still some people do have a metal allergy. So in your intake, you may want to include that question in the process. If they have an abnormal bleeding tendency or some sort of a peripheral vascular disease would be a precaution. Additional precautions, people that have implants, breast implants, we do a lot of needling around the coracoid process, around the chest itself. There are ways that we can needle around that. Frequently it involves getting additional consent, and then the patient themselves may have to help move or identify that implant so that we stay away from that structure. Person that has a laminectomy, we'll talk about this in a bit, but if you've had a laminectomy and you're dry needling into any of the spine and you're using that lamina as a backdrop, which we do, if that lamina is now gone, you no longer have that backdrop, so you have to significantly shallow your needle depth or try to dry needle into a different location. Scoliosis, similar. That with scoliosis, the vertebrae themselves are going to rotate depending on the side of the curvature, and so you just have to be aware of how that's going to affect the landmarks of the spinous process, transverse process, and the lamina themselves. And then severe osteoporosis. It's just a precaution. in the scapula itself. There are cases where a person with severe osteoporosis can actually have holes, a foramen in the body of the scapula. And so if you're counting on that being a reasonable backdrop and you manage to somehow get into that foramen or that hole caused by osteoporosis, then you could be find that you are actually needling into the lung field. So just something to be cautious of. And all that's off of a study by White. It's a little bit old. It's back from 2001. Just the potential complications there. Well, that's this next group. So common potential complications. One is needle insertion pain. The question is, does it hurt when the needles go in? Well, I mean, it's not a feather. We are inserting a needle through the skin. That's usually not that significant of an issue, depending on where you're doing it. If we're doing it on the face, if we're doing it on the hands or on the plantar surface of the foot, that one is always going to be a little uncomfortable. But basically, you're going to feel that crampy, achy sensation once the needle hits its target. So there will be some needle insertional pain. I would say that one may not be as low as 1 to 10%. That one's going to be a little bit higher. Muscle soreness can occur. At times it can last for 1 to 2, sometimes even 3 days post needling. You can have some fatigue after dry needling. You want to encourage rest and fluids after needling. Some light physical activity that same day may be appropriate as well. I rarely will tell a person to let's do this dry needling and then go do your big exercise. If they're not in the midst of doing a lot of heavy exercise in the first place, I wouldn't have them start that day. I'd have them maybe a little light stuff and then try to ease back into it over the next couple of days. From time to time, we will have some bruising with the vast amount of the venous network throughout the body. It's inevitable that we're going to pierce through a vein. By and large, arteries with a thicker wall are going to move out of the way of the needle, so there's less concern there, except for the much larger arteries, and we'll talk about the big ones in a little bit. But there will be some bruising as you do hit some of those smaller vessels. I just try to let patients know up front you might have some bruising. If I do have a little blood that comes out when I remove a needle, that absolutely will cause a bruise, and I want to let them know to expect it. As if they know up front, they're much more comfortable about it the next day when they see that bruise that's developed. Much more uncommon here, 0.1 up to 1%, can be an aggravation of symptoms. Every once in a blue moon, we do see a patient that has a symptom exacerbation after dry needling. It's not the end of the world. If it happens, you should just reflect upon the treatment and discuss further in reasons for ineffective dry needling and make the appropriate modifications. I like to let my patients know that there is a small chance that could happen. I get more concerned if there is absolutely no response at all. If we do see an aggravation of symptoms, it's more likely that we've solved one region of discomfort, one area of tenderness and pain, and we found an underlying issue that's going on as well. So I never look at it necessarily as a negative. It's just something for me to evaluate again. There are some people who get feeling of faintness or dizziness. I've had quite a few people get faint or dizzy. I've had 2 actually pass out or have a syncopal episode. I've had 1 who lost control of bladder. So these things do happen. As a rule, our first treatment episode should always be in the prone or supine position. That's what I'm going to recommend in my treatment protocols initially, will be focused in that position. If you have 3 needles they've got a patient sitting on the side of the table, you've got 3 needles, they're standing behind, you got 3 needles in the shoulder, and you don't realize that they're passing out. You may find that you don't have anything that you can do. You've got to ignore those needles or grab them really quickly. Somehow you've got to protect that patient. So good general rule of thumb, especially the first time that you needle a patient, is to have them in that prone position. The faintness, dizziness usually subsides within a couple of minutes, and it's just a vasovagal response. So it does happen. Occasionally there can be a stuck or a bent needle. It's uncommon. It's associated with an aggressive muscle contraction, secondary to local twitch response, or a patient contracting the muscle being needled. To alleviate that, we're going to relax and wait, or we can use electrical stim on the needle. We can change pressure with palpating hand. We can insert an adjacent needle. More often than not, I find that stuck needles can happen, and not necessarily stuck. That tissue can really, a good hard contraction can really grab a hold of that needle. So, and we'll demonstrate this in a moment. We can do a little needle manipulation, and that will help release that needle coming out. A bent needle does happen, especially in the lumbar spine. The muscle contraction that goes on in the erector spinae group can be extremely powerful. The first one I saw was on a young patient. The second one I saw was one that was inserted into my back. I had a hard spasm, and that thing came out, looked like a lightning bolt. It's not the end of the world. We take it, we retract it, and we dispose of it in the sharps container. One thing that can happen is the only issue that I've ever had with a needle is not a broken needle or an infinitely stuck needle, but is a needle that, so we looked at, let's see if I can bring this up. So a needle has, this is going to be challenging. So if you can see, there's the shaft of the needle itself and then the handle. Well, the handle is basically it's a wrapped wire like a guitar string, for anybody that knows what that looks like. And so they're not attached, it's just held together by pressure. So I have had the handle come off before. But the needle itself extends all the way to the end of that handle, in which case I just grab and retract the needle. If for some reason that needle does break below the surface of the skin, one of our objectives, one thing we can do is provide a little pressure on the skin, and that needle should pop above the level of the skin, in which case we can take some hemostats, tweezers, pliers if you have to, and just remove that needle. If for some reason you're unable to retract that needle, a broken needle from below the surface of the skin, they do need to go to the emergency room and have that removed. Again, 500,000 needles. I've never had one do that, knock on wood. But that would be the process to remove that from that situation. Infection is 0.01% to 0.1%. Likelihood of infection is extremely small. To date, again, knock on wood, I've had 0 incidents of infection from dry needling. I'm certain that there are some reported incidents out there, but as long as you follow clean needle technique, that should not be an issue. Pneumothorax, again, extremely rare, but this is the one that we really get concerned about. There are videos floating around on the internet that show a dry needling instructor, an MD actually, dry needling onto a colleague in the rib cage, and talking to the students, talking to the class, and just pistoning that needle past the rib into the lung field, and that person ultimately ended having a pneumothorax. So pneumothorax, we're going to repeatedly say that we want to be cautious of that. And then the other, again, the less than 0.01%, I think that's a little low. Maybe 1 in 100 have a vasovagal reaction. Here we're needling very tender and sensitive points, and it can elicit that reaction. You get cold sweats, lightheaded, and again, you can even pass out from that. Here, they typically recover very quickly, and again, that's why we keep them in a supine or prone position the first time we needle. So we'll move on and talk a little bit about danger zones. Several locations in the body that require even the experienced dry needler to take caution due to the proximity of body organs, nerves, and blood vessels. In this course, well, the original in-person course, Foundations and Fundamentals, is designed so that the structures being taught and needled will minimize the risk of the more potentially problematic areas. With that being stated, there's always potential for complications in even the most basic dry needling protocols if the clinician is performing the techniques away from the established procedures outlined and taught in this course. So I took great pains to look at specific distances, locations in the typical person, and we use a measuring unit that's consistent across different body parts. and that's each patient's thumb and finger widths. In some cases, we can throw 4 together or a palm breadth. And that gives us the ability to be very specific in our location. So if you follow the protocols and the distances and the directions laid out here, should not have any problems in the danger zones. So here we're going to talk about, well, let's start with them. Anywhere in the suboccipital region, atlas axis. Here the problem here is the spinal cord, the cerebellar tonsils, the spinal ganglia, the nerve roots, and then the vertebral artery and the deep cervical vein. So we mentioned this is a really bad area if somebody's got a Chiari where the brain structures themselves are coming down from the foramen magnum depending on their depth. There are several suboccipital muscles right in this area that are very effective for dry needling to deal with tension, headaches, and so forth. So if they do have a diagnosis of Chiari, you've got to stay away from that. You just got to find another way to deal with that, because we just wouldn't know where exactly that structure, that Chiari structure would be sitting. Another in the supraclavicular triangle, and here we're talking about just above the clavicle. And there, obviously, we've got a significant number of the nerves, the brachial plexus coming through, and then the vascular structures heading out towards the arm itself. So definitely want to try to stay a couple finger breadths above the clavicle in most of the needling sessions here. So I'd mentioned earlier there's a muscle that I really want to figure out how to safely dry needle. Well, this is it right here. It sits dead inside that supraclavicular triangle. I'm going to keep working on that to see if we can't do something there. But anyway, we want to stay away from that if at all possible. Here we've got the brachiocephalic trunk, the subclavian artery, common carotid artery, and the axillary artery. We also have the brachiocephalic vein, internal external jugular vein, the subclavian and the axillary vein, and then the brachial plexus, and then the apex of the lung can come high even above the rib cage. So at times that lung apex can be very high. So a good rule of thumb, come up 2 finger breadths more cranial above that clavicle. In the thoracic spine and the rib cage, another potential big danger zone. We know the width of the lamina of the thoracic vertebra. So here, obviously, if we go too far lateral, we run the risk of needling into the lung field. It's the big no-go there. And so that's even if we're going this way. If we try to needle onto a rib, boy, we really have to be careful, because that area is just wide open. So the thoracic spine, the rib cage is a big area where we want to stay really nice and close into off the spinous process. At the iliac crest, yes, there are things that we want to dry needle here. We can catch a lot of the abdominals either on the anterior or on the lateral aspect. If we want to dry needle into the iliacus, which we will look at, we can get it on the inside. We just have to be careful of all the viscera that's sitting in that location. At the TL junction to L2, here our concern is for the lungs. You can see they drop down fairly low, and at the same level we have the diaphragm supporting it, and then the kidneys are just sitting right there. The TL junction down to L2 is the more narrow area of the spine itself. The lamina get much more narrow, which is a really odd situation, since that is a critical junctional zone for the body. A lot of our dysfunction occurs 11, 12, 12, 1, 1, 2. So we just want to make sure that we cheat in a little bit more narrow when we're needling into this TL junction to avoid those structures. In the femoral triangle, we definitely want to be cautious here. We have the sartorius, the floor is the pectineus, and adductor magnus, the adductor group, making the medial border. In here we've got femoral nerve, femoral vein, artery, and nerve. Got to be really careful in there. This nerve, this artery and this vein are probably more susceptible to injury doing some dry needling here. If they weren't there, we would have a lot easier time dry needling some of the structures here. Fortunately or unfortunately, they are there, so we have a way to identify where these things sit and where we can and can't safely needle to that area. Again, femoral nerve, artery and vein, the external iliac artery and vein, and then the suprainguinal viscera. So also have to be cautious in that femoral triangle that we don't go too cranial into the visceral compartment. In the sacrum, coccyx, and the buttock region, the main thing we get concerned about here is needling into the sciatic nerve. We have really nice ways of knowing exactly where that is, but we definitely don't want to drop a needle into that large nerve. It will light a patient up very quickly. So also if we go too deep with too long of a needle, we've got the rectum further anteriorly. We also have the superior and inferior gluteal arteries and veins. More than likely they will get out of our way, but really that sciatic nerve is our big issue right there. We move further into the cubital fossa. Here we're concerned about the brachial artery, basilic vein, brachial veins, the median cubital vein, and more specifically the median nerve. We do dry needle for the median nerve, both proximally and distally here, but cubital fossa itself, good area to try to stay away from the center there just to avoid those structures and potential injury. Further into the popliteal fossa. Here we'll look at the femoral artery, the popliteal vein, the small saphenous vein, and then the nerves, both the tibial and then the fibular nerve coming down a little bit further. Okay, we talked a little bit about dizziness or lightheadedness. Pregnancy, there really is no noted connection between dry needling and miscarriage or other pregnancy complications in any of the 3 trimesters of pregnancy. Again, most common trimester for miscarriage is the first, so a good medical legal reason to avoid dry needling during that time. Again, as you get more experience, it does become a lot more comfortable to do that, but you definitely just want to have a frank conversation with your patient about potential benefits and drawbacks related to that. And then post-surgical lymphedema. Anytime that's going on, we want to stay away from that. So surface anatomy, we talked about the location of specific needle placement in order to remain completely safe with our dry needling. So it becomes critical for safety itself, number one, to be able to identify all of the structures that we're going to dry needle. If we can't identify it, how on earth can we dry needle it? So in addition, we also need to have very good palpation or manual skills in order to help diagnose which of these structures are the focal point of discomfort. How do you know which muscle groups to needle if you can't identify where these things are? So as we move through, we'll go through a lot of really good surface anatomy and palpation skills to be able to identify these structures. I don't spend as much time talking about frontal, sagittal, transverse, horizontal planes, but from time to time we do need to know what that looks like. This will be here in both your notes and in the recorded lecture for your reference if you need to know those things. So some general dry needling considerations. Needle placement location is really determined with the first consideration for safety to avoid the danger zones. And the second consideration for maximal therapeutic effect. Needle location is frequently determined as a certain number of finger or thumb breadths from an anatomical structure, which you'll identify in the palpation labs. Excuse me. When we refer to a finger or a thumb breadth distance, we want to remember that it's the distance of measure. It's based on the finger or thumb breadth of the patient or the subject, not of the clinician. So I'm 6'3". I've got really big claws here. If I take a 4'11" small framed person and I use my finger or my thumb for point of reference, then everything is off. So whenever you're looking at your placements, definitely keep an eye on what unit of measure you're using, and it's the patient's. As an example, when we're using dry needling in the spine, we always use the spinous process as a reference point. And specifically when we do that, we're talking about the upper lateral border of that spinous process. And so then we'll look at 1 or 2 finger breadths away from there, depending on the location. So let's talk a little bit about some hand grips and such. So in the areas where there's a bony palpable bony linear surface, such as the spinous process of the spine, the tibia, or the spine of the scapula. The tips of the fingers can be used to hook over the bony landmarks. So I can come in, let's move here, and just hook. I'll use a profundus grip, and I can grab that structure, and I can use that there. When inserting a needle, we're going to first determine the desired needle placement location, and then we're going to use the index and middle fingers to apply firm pressure as you splay those fingers apart to tighten the skin. So if we just try to drop a needle down into the skin itself right here, the skin's going to bunch up, and it's going to be a lot harder to get that needle to penetrate. But if we spread that skin apart or splay that apart, then the surface tension decreases, and it's a lot easier to get that needle to pierce through that barrier. So when we do that, we're going to splay apart. We're going to splay apart, and then we're going to rapidly tap the handle of the needle that extends beyond the insertion tube to quickly depress the needle through the outermost layers of the skin. We'll then remove and dispose of the application tube, grasp the handle of the needle in preparation of advancing the needle in the desired angulation and depth with or without a backdrop. Can also be useful in bracketing and target tissue such as brachioradialis. We can identify it. We can then bracket that. This is complicated to identify the target that we want to get. A lot easier to display that sucker right there. Gets us what we want there. On some needle manipulation, there are several things that we do here, and I'm going to discuss it, and then we'll demonstrate this. Needle manipulation can be an extremely effective tool to elicit the spontaneous electrical activity, the SAE, or the twitch response. In the acupuncture world, it's known as the Deki sensation. From our trigger point group followers, we do what's called pistoning. And I give them a little bit of a hard time. There are times I will do some pistoning. And that's honestly just moving that needle up and down into tissue. The reason they try to do that pistoning is if we want to specifically identify a trigger point, well, we could, and they're looking for this magical twitch response. You frequently get it in the upper traps, and different muscles in the body are more prone to it. But if we drop the needle and we don't get that twitch response, their approach is to reinsert that needle back and forth. Again, research shows us that we don't have to do that. We get great results without doing that. Plus, I don't want anybody when I go give blood, I don't want them hitting that thing 6 times. You get it once and be done. And research supports doing that. We can also do some rotation, both a bidirectional and a unidirectional. The bidirectional is at about, again, we're just going to go about 90 to 180 degrees, and it's at about 2 cycles per second or 2 hertz. So it's not extremely fast. And there that can get a similar response to getting that twitch response, if that's what you're looking for. The one I use more commonly is unidirectional rotation. And this can be performed between the thumb and the index finger, and you rotate that needle in a single direction. Anywhere from 2 to 5 seconds, in some cases longer. The tissue collagen is going to wind around that needle, and it's going to become stiffer with that rotation. We can use that to elicit that twitch response. It can also be used, and what I use it more for is a tenting maneuver to mobilize the underlying tissue in a direction in the same plane as the needle. So if I'm needling into a specific tendon, or specifically when we dry needle for tenosynovitis, I will place a needle in there. I will get a tenting action, really attach that needle to that structure, and then I can mobilize that tissue back and forth. So unidirectional rotation can be very nice with that. Care should be taken with pistoning, bidirectional and unidirectional rotation, to be aware of the depth of the needle that you have determined to be most therapeutic. So what can happen if you're doing pistoning, if you're doing some rotation? So I'm sitting here and I've got a long, let's say I've got a 3 centimeter needle, and I'm really busy. I'm pistoning, I'm going, and I'm doing my thing. I get sidetracked over here doing something else. If I'm not careful, I will basically piston that needle all the way through my target structure. And we just have to be careful for that. I've never pushed one all the way through, but if you're doing that, really close attention to what's happening so you don't go beyond the depth that you intended. Some conversation about the different grips. Lumbrical grip, basically, we're using the lumbrical muscles to grasp. So in that case, I may find, let's see here, that certain areas I want a targeted grip. I need a lot of mass, and so I'll use that lumbrical grip to do that. Here we're going to, the PIP and DIP are being full extension. In the profundus grip, again, that's really good for hooking, again, the upper, the spine of the scapula, clavicle, the tibia, the spinous process. A lot of times that we will want to use that profundus grip just to hook around to grasp our structures. And then the pincer grip, very fancily, we're going to use thumb and index finger to target and isolate that structure that we're looking for. Another critical component is in needle redirection. I will be honest, this takes a little time and a little skill, a little practice to get comfortable with that. So, and I use my example of tennis elbow. So I'm out here and I'm trying to needle onto the common extensor tendon. And so I try to get in there and I realize I haven't hit my target. It's really small, so I really don't want to come all the way back out. What I really want to do is use my fingers and retract the needle a little bit and pull the skin away. And by definition, that's going to move the orientation of that needle on the superficial aspect as we then reinsert back down into the deeper tissue. So I can reposition the final location of that needle based on how I mobilize the skin on top. And we'll demonstrate that a little bit. So to redirect proximally or towards yourself, you're going to retract the needle and you're going to push the skin away, and then you can reorient the trajectory back to you. Likewise, if you want to go distally, then you pull the skin toward you, and then you can redirect the needle away. So a little demonstration here, and I'm going to switch again to this. All right, let me stop the share. All right. So I've kind of demonstrated the hook, the splay in the bracket, the grips. Let's talk about the peach and the apple and the needle manipulation. So I always like to use a peach because a peach has a nice pit. Plum can be used as well. Unfortunately, apparently this isn't peach and plum season. So I've pulled out an apple. So as part of your homework, the first thing we talked about is I wanted you to work a little bit on re-sheathing a needle, just using the needle, manipulating it. Another thing I want you to work on, and I just want you to shoot a short little video of using an apple to insert your needle. So it's really important. Number one, we want to, if this were skin, I would want to splay and bracket and create some nice tightness on this skin. As we place the tube down, one thing that's really important is that we put enough pressure. So if you don't place that needle down and give it a little extra pressure, and so for me, I'm going to come in and let's see, orientate. So I'm going to take, I've got the needle pulled away. The needle is nowhere near my skin, but the guide tube is. I've created a depression in my skin. And that extra pressure on the guide tube also gives you a little bit more surface tension, or it takes away a little bit more surface tension to make it easier to advance that needle through that skin. So on your apple, you have to be careful because if you push too hard on your apple, you're going to push through the apple. So I want you to simulate pressing, making good contact on that apple. And then the real challenge is in a rapid tap onto the top of that needle. And then you can pull it out. And then from there, you just want to advance that needle in. An apple will have some piece of a core in there, so you'll get there and you will feel it hit in there. Most of the needling that we do look for a bony backdrop. And so that is a nice simulation of a backdrop. If it's a small apple, be careful on the other side. With regular human skin, as the needle approximates the exit point of the needle, we will feel pressure on the apple that's just going to come through and poke you in the finger. So be aware of your needle length. So that's number one, is just getting some good practice on re-sheathing, dropping, and advancing the needle. There are lots of ways of doing the tap, depending on the location. I tend to do just a tap with the end of my index finger. I'll keep my finger bent at the joints. It can also be done with a straight finger. Either way like that. It can be done a third way, and that's with a thumb on the other side, like such. So the other thing that we talked about a little bit was the needle manipulation. So we come in, we get a nice, whatever our target structure is, we get it there. Let's say I'm a trigger point. Let's say I want to go get a trigger point, and I insert my needle, and I don't get that magical twitch out of the muscle that I'm hoping for. So what I can do is what they refer to as the pistoning, and I can just reposition that. Now, unfortunately, in the apple, I can't really move the needle around it and really change its orientation. But that is, pistoning is just moving up and down, trying to hit more of that tissue at one time. I rarely do this, simply because I don't want it done to me, and research tells us that we don't have to be this traumatic to our tissue in order to elicit the response that we don't. But most of your motor trigger point theory is based on pistoning. The second approach is unidirectional and bidirectional rotation. So bidirectional rotation, again, between the thumb and index finger, at about 2 hertz, I'm just going to rotate it right there. It sounds odd, but you can get a good response from the patient. You can start to get that muscle contraction, which is that crampy, achy sensation that we're looking for. So we can get that. And then the third, which is the unidirectional rotation, and I'm just winding this in a single direction. I can wind, now it's not going to in the apple, but in a collagen-based human, that tissue will start to wrap around that needle. And then it will get tight almost to the point where you really can't move it any further. From there, I can then tint that tissue and pull it away from the body and mobilize that specific muscle deep to the body and get a very good response there. So, again, as far as the homework, we want to look at needle manipulation, or re-sheathing, I should say. Again, just practicing dropping the needle in. There you can see. So I'm just going to drop it in. That way I'm ready to needle there. We want to look at the actual needle penetration, a very rapid application. And then we want to look at pistoning, bidirectional rotation, and then unidirectional rotation. That's the extent of it. Since we're here, I also wanted to demonstrate different needle sizes that we have. So this needle is 5 centimeters or 50 millimeters in length. It is 0.3 millimeters in diameter. That's fairly standard. We have a smaller needle, which is, this is 2 centimeters. There's some that I use that are 1.5. I don't really use anything shorter than 1.5. 2 centimeters, I think you can see that adequately. 2 centimeters, let's move up a little bit. Let's go, no, there. And here. And my most common needle that I use is probably a 6 centimeter. But depending on the location, we have also up to a 12.5 centimeter. And so you can see a big difference in length of needle. Each of these needles are the same diameter. So with this large one we talked earlier, you can see it's a much longer handle. If I try to advance this needle into this, I'm going to come back up here, into this apple with my tube. I can get it here, but if I try to advance it, you can see that needle is just going to bend. And so with my gloved hand, I can then assist that needle in. So, and yes, there are times when we need a much longer needle. We'll talk about when we get to that, when that would be necessary. Okay. Let me jump back to here, go back to our share. All right. A little bit of conversation about electrical stim. It's rare that I don't stimulate my needles directly. Here's a study that talked about using oxygen in tissue. They looked at 1 hertz. They didn't see a significant change. Jumped up to 20 hertz. Saw changes there in muscle fatigue and muscle pain. This is more about acupuncture treatment. Using that to facilitate blood flow, oxygen supply, a little bit higher frequency can be quite beneficial. Another application it demonstrated that electrical stimulation to the needles themselves was more effective in eliciting the responses that we were looking for than just dry needling alone. Here they looked at up to 2 to 5 hertz. From our own gate control theory, we know that use of the gate can be helpful to alleviate through TENS the pain management. There they look at anywhere 90 to 130 hertz. For our lower frequency, that other, it's 2 to 5. I like a burst approach, so we get a little bit of the best of both worlds. So especially if it's a more chronic, subacute to chronic stage, I will do a split frequency of 2 to 5 hertz for about 3 seconds, and then I will adjust that up to a high frequency up to 100 hertz for 3 seconds, and then we'll alternate back and forth. That seems to give a little bit better response, especially with our subacute and our chronic patients. I'm going to move past that. Our acute people that come in, I will typically stay at a low frequency of 2 to 5 hertz. So I'm going to put up here. For those people, our very first time doing a dry needling session, I'll normally just use what we call a point stimulator. These are relatively cheap as far as TENS units or stim units go. We have quite a few of these. People tend to tolerate this. I'll normally stimulate the needles in their position for 10 to 20 seconds each needle, especially that first, second session. If that doesn't respond, then we'll move on to a different type of a unit, if I can avoid throwing it down. And so I'll just demonstrate this. And I can list these out if you want those. This is a 4-channel unit that will let me adjust for a different burst program. I can put up to 8 needles on these 4 leads. There's another unit that we use that has 6, so I can go up to 12 needles on that. I can also use different units on the same person. I normally won't do that. If I have a case of a patient that has a lot of needles, I think my high is probably, I've had as high as 26 needles in one single patient. It doesn't happen very often. His was a special situation. I'm not going to stimulate all 26 needles. I'm going to find a nice grouping and get those in there. But the point is that electrical stimulation can be a big plus in reducing the symptoms that we're trying to deal with. And then finally, a note concerning recommended needle length. So as we go through this process, we're going to look at a lot of information on needle length, needle depth, needle angulation. It's really determined on a patient's body habitus, and it can change drastically the length of the needle required to reach our target depth. You will needle some patients within a recommended BMI, and some that are way off the chart, either under or more often more over. The recommendations in this manual are designed to ensure safety in most every adult patient population. As you become more skilled in the techniques that are taught here, you'll discover that with a larger body habitus, you're going to need a longer needle to reach those target structures. There's no one body is the same. Again, the needle lengths recommended here will ensure a safe beginning down the road of mastering dry needling. Again, more often than not, to be extremely therapeutic, I probably am using longer needles than anybody because it's a lot easier to reach that therapeutic depth. When I first started dry needling, I went with a lot shorter to make sure that I wasn't injuring anybody. So what I've put in is to ensure your safety, the patient's safety, and let you learn the techniques without compromise. So a quick conversation about dosage and frequency. That's always a question that I get from patients and from other clinicians. So how do I determine that? Most cases I divide into about 5 different categories. And dosage and frequency is determined on their activity level, the chronicity of their condition, the response to treatment, and probably the most important factor is their compliance or their willingness to be compliant with a well-developed home exercise program. I'm a massive believer in the effect of dry needling as a treatment modality to address our first phase of healing. That being said, it's only a modality, it's not the cure, and belief that is the cure is false. Dry needling is needed, as is any other modality, to address a neuromuscular response to a biomechanical dysfunction. That dysfunction can only be addressed through a change in mechanical function, flexibility, and strength. Yet, when properly applied, dry needling can be the most effective tool we have in our arsenal to address that phase 1. This is the only tool where we can physically touch the source of the patient's pain. More often than not, when you dry needle, whatever the condition is, day 1 after you go through that first lab, this will be the first time that somebody says, yes, that's the pain that I've been dealing with for all this time. And so it's a great tool to let us finally have that one-on-one touch with that. So dosage and frequency are 5 classes. Number 1 is the athlete. There are 2 stages here. 1 is an athlete with no comorbidities. Here the issue is new. It's been within the first 10 days of injury. They have not had a significant deviation from their strength or performance level. Frequency of dry needling here, it's going to be 1 to 3 sessions within the first 3 to 5 days. Prognosis is excellent, and they'll be able to resume normal training within 2 to 4 days. They're going to have 1 or more comorbidities, or this is the second group, if they have 1 or more comorbidities. Still an athlete, but the issue has moved to a subacute stage 14 days plus. They hoped it would go away. Maybe they saw the trainer, things just didn't change. Here they've begun to have some asymmetries in strength and performance. Frequency of dry needling here, it's going to be 3 to 6 sessions within the first 3 weeks. Prognosis again is going to be excellent. They will need 2 to 3 weeks of training to restore their asymmetries, flexibility, strength, etc., and then they can resume their performance training. Second one is our average Joe, our weekend warrior. This person's in decent physical shape. They had some incident that resulted in a strain or an overuse injury of a localized muscle or group of muscles. Here, frequency of dry needling is usually just 1 to 3 sessions within that first 3 to 5 days. Again, the prognosis is excellent. They'll need to adapt an ongoing HEP to address the mechanical deficit that set them up for the injury. So they may have been really active, they're decent, but there's some underlying something that's been going on, and their weekend activity just brought it to the surface. Boom, they get injured, and now here we are. So dry needling will knock that down, but they're going to have to address whatever caused that to surface in the first place. The next is our quick stick. Quick stick, this is our work colleague, somebody who slept wrong. They need a quick fix. This is somebody who says, ooh, you do dry needling, I have this. And you go, they come see you see them. And you're going to get a lot of this. As people learn that you dry needle, you're going to become very popular. Here, the frequency of dry needling is going to be 1 session. Their prognosis, however, it's just fair. They'll have some underlying condition that will need compliance with an HEP to correct, but they won't be willing to accept that fact and be willing to do the work. There's a decent chance this person will move on to the next stage, which is the procrastinator. The procrastinator has 1 to 3 comorbidities. They've been dealing with the pain and functional complaint for several years. They're unable and unwilling to deal with the issue due to a variety of either valid or invalid reasons. Now they've decided, I'm going to do something about this, and they start doing their stuff. Here, the frequency of dry needling, it's going to take 8 to 12 sessions, first 30 days. It's going to take them a little bit of time to get where they need to go. The prognosis is good, however. Their success will depend on if they will continue to do their work. If they're going to do what you've assigned to them for their home exercise program. Again, it's about decreasing inflammation, restoring flexibility and motion, and then bringing strength and function back to a normal level. If they'll do their part, our part's easy. And then finally, it's the hard case. Here there are multiple comorbidities that we have, either severe OA, DJD, some other significant issues that really and truly would require surgical intervention or some other intervention that can't be done either to medical or personal issues, such as they can't get cleared for surgery due to pulmonary, cardiac issues, any number of reasons why they can't have what really would be needed medical attention. Here, the frequency of dry needling. The first 30 days, we're going to look at 8 to 12 sessions. The next month, we're going to look at another 4 to 8 sessions. So we're going to start weaning this down. First month to really start decreasing that pain and inflammation. By the time we get to the third month here, we're looking at 2 to 4 sessions a month, and we'll probably do that beyond from there. Prognosis here is fair, but let's be honest, this is long-term maintenance case. Insurance may be an issue, and it may require a cash pay service depending on their payer. Treatment actually will be required until interventional clearance is obtained. This is non-pharmacological pain management. Dosage may have to be adjusted based on their condition, and treatment should improve their functional outcomes, but withdrawing or discharging the service will result in a return to their prior condition. There is limited improvement with a progressive HEP. These are people, they need surgery, they need the knee replacement, they need the hip replacement, or they've got an underlying condition that just won't let them undergo whatever that situation is. It is non-pharm pain management. And I'll be honest, I think that we are a better choice to do this service than to be stuck on fentanyl or a large number of the other pain medicine options, painkillers that are out there. I do have a patient that I've been seeing, well, a couple that I've been seeing for several years that we're now out to. I see one of them once every 6 weeks. I see her one session for a specific protocol that she'll learn later, and it significantly improves her function. It improves her quality of life. Her pain meds are still at a minimum level, but if we stop doing it, that inflammation is going to come right back. So that's the hard case. So lecture number 2, we are moving very well here. We've got just a few minutes left here. So lecture number 2 is going to be, Ashley can jump on here in just a second and remind us. It's 2 weeks from now, if I'm not mistaken. When we get to lecture number 2, here we're actually going to start talking about some surface anatomy, some three-dimensional anatomy. We'll look at our needle placements, supporting evidence, clinical decision-making. We're going to start in the cervical and then the lumbosacral spine. In the cervical spine, we'll look at splenius capitis services. In the erector spinae, we'll look at spinalis services. Longissimus and iliocostalis will come a little bit later. Then we look on a little further superior semispinalis capitis and services. And then finally, the cervical multifidus. When we get to the lumbosacral, we'll look at the interspinalis, longissimus, iliocostalis, multifidus, and lastly, the PSIS. There will be a little bit of carryover material that we weren't able to get to today, but hopefully it'll be a little bit more entertaining than just me reading stuff. Again, I hate this first lecture. We've got a lot of information we've got to get to on theory, on physiology. That's important for us to know. We need to get this initial playing with the needles out of our grasp and learn to do that. On your homework, definitely want you to work on that. And we'll talk about that again in just a minute. Again, I mentioned the 3D anatomy applications. I didn't get a chance while I have And we'll get into all of that next time. So the one that I look at, I've used several of these. The one that I use more than anything is Complete Anatomy through 3D4 Medical. I have publishing rights through that company, and I've been using them for several years as far as both the content that you'll be looking at, but also as far as is rebuilding our idea on dry needling and where we're looking for specific structures, specific locations, and how to stay away from the danger zones. So I would encourage, I'm not going to require it, but I would encourage you to look at some of these offerings. I also like it because they're the cheapest one that I found. But that's not why I use them. I use them because they're a great platform. Any of the others are good. There's a free one down here, this BioDigital. It is cumbersome. It is not worth your time to mess with it. But if you want to look at something free, go for it. 3D4 Medical. Most of these others as well have either on the PC, on the iPad, or on your phone where you can work them as well. All of my content is actually loaded and saved into 3D4 Medical. I'll have to change it a little bit for this hybrid approach, but they're there for review later on if you want to look at that specifically, as opposed to just watching the videos of me demonstrating and discussing the anatomical structures that we'll go through. So, for the post-lecture assignment, if you haven't, I need you to go to request to join the closed Facebook group. It's called the Dry Needling Arena. It is here. So this is the location where we will take a look at. This is where you're going to post your homework. It's closed. Nobody can see it except people who are members here. And so here we go. So March 15th is our next lecture. So after we finish this lecture, I will come on and I will load the homework assignment in here. Just make a post about it. If you'll reply to that post once you are a member of what your homework is, it doesn't have to be done today. I don't expect you to, if you have needles, to go start filming right now. But over the next couple of weeks, if you can load that before the next lecture, that would be fantastic. So for our other homework, I want 3 questions and then a little short video. So question number 1, I want you to name 3 contraindications to dry needling. Just enter that in that dry needling group. I want you to name 4 of the danger zones, and then I want you to identify 1 possible factor responsible for muscle tension and pain. These are also in your student portal for lecture number 1. And then lastly, a short video of if you can find a peach, great. The apple is a nice substitute for needle application, needle re-sheathing. I didn't put re-sheathing, but I want to see re-sheathing as well. And then some needle manipulation. The needle manipulation will be the pistoning, unidirectional rotation, and bidirectional rotation. And so that will be your homework for the next assignment, before the next course. And again, if you're watching this asynchronously, you still need to, and you want the CCU credit, you still need to submit these homework assignments to that same page. I will jump over to Ashton really quick to see if there are any questions from the group. I know it's a whole lot of information in a really short time. I promise my goal is not to just flood you with information, but there's a ton of information to get out there. So if you have questions, feel free to jump in, send it to me. You can email me, or you can drop it to me through the Dry Needling Arena. You can send it there. But I'm excited to have you all aboard. And Ashton, did you have anything?
No, we don't have any questions.
Fantastic. Everybody learned it all. Great. Next time we'll start getting a lot more fun. We'll get into the nuts and bolts of where we're going to put needles and how and in what depth. We've got 3 more lectures, and then we'll meet for the first lab session. So thanks everybody for watching. And if you haven't, go like our Facebook page. That would be fantastic. All right. Any questions, let me know. Otherwise, we will see you in 2 weeks.